Welcome to today's webinar, Swallowing, Eating, Nutrition, and Dental Health with Dementia Patients. My name is Amy Craven, and I will be presenting today. So, what are some of the effects of dementia on the nutritional status? In the early stages, you may see weight gain. Their hypothalamus is not working correctly. They may not feel full or forget that they've already eaten, and they may eat numerous times during the day, maybe not things that are so nutritious, or they may have poor appetite and not be drinking enough fluids. With the progression of the disease, you may see weight loss. They may not remember to eat. Or you could see the refeeding syndrome, which is a syndrome consisting of metabolic disturbances that occur as a result of reinstitution of nutrition to patients who are starved or severely malnourished or metabolically stressed due to an illness. They have increased nutritional requirements. They may not be getting the vitamins and minerals that they need. They may also have GI disturbances from some of the medications that they're taking, and that could affect their appetite. As we age, we're also going to see decrease in oral saliva and muscle mass, which helps with chewing. We may lose some of the oral motor strength and coordination in our mouth. So what are some of the possible other causes in dementia? Depression can be a cause. Issues with communication. They can't tell you that they're hungry, or maybe they're not telling you that they don't like the food. They're having difficulty communicating that. Or they have pain in their oral cavity and it's uncomfortable to eat. Or are they just so overtired because they're not sleeping, and then they have no desire to eat because they're so tired. Or that lack of physical activity. They're not moving around as they did. They're not exercising, so they don't need as many calories. Or is it medication changes, or if they had a change in the dosage of their medication, a new medication that could affect their appetite. Or are they constipated? And again, they might not be relaying that to their loved ones, that they are having issues with moving their bowels. So what are some of the other difficulties? Their motivation. In the early stages, we may see apathy, and they just don't have the energy to get up and make something for themselves. Or it may be too difficult so they're avoiding preparing or cooking food. Or do they just not have that ability to recognize that they're hungry? Concentration, lack of recognition of certain foods. They may have dexterity issues, both mental and manual. Their cutlery may become difficult to use, or they've forgotten how to use it. There could be environmental issues that are affecting their ability to eat. They're too distracted. There's too much going on. They're not able to tell you what they like and dislike, and they really don't like the food that's being served by their family or the facility where they are. And their food preferences may change. I know my mother, who's going into stage 5 now, never liked anything with gravy. My husband, I was out of town and brought her dinner the other night, and it was a stew. And she called him to tell him how much she loved it. Maybe it was because he brought it, though. And it wasn't one of her daughters. What can we do to encourage intake? Make foods look and smell appealing. Ensure proper temperature. Think about what they tell you when you're going to show your home for sale. They want you to, I know they told us to bake cookies before we had a showing because it makes the house feel homey and welcoming. Well, that could work with the Alzheimer's patient. The smell of freshly baked bread or cookies or other baked goods or foods that they really liked can make things more appetizing. Different colors, tastes, smells, not serving them the same thing all the time. Maybe changing the portion size. Don't overload their plate with too much food. That can be confusing. We had a patient that we served one item at a time, And the speech therapist has suggested that, and then we were successful getting him to eat. Otherwise, if there were too many things on the plate, he just didn't know what to do first. Stronger flavors, remember they have that remaining taste of sweet and salty, so add sweetener to food, maple syrup, chocolate syrup, honey, simple syrup. Capitalize on those sweet taste receptors. Serve half portions, maybe keep the other half warm, or alternate things. Give them a little of a vegetable and then serve them a little bit of a starch, or a little bit of a protein. Keep alternating and then go back to the starch. Don't serve them a large portion of one thing at a time. Another thing that I learned from a speech therapist, I was seeing a patient in an assisted living and they were having lots of problems with this woman eating. And the speech therapist suggested that they give her a receipt at the meal, that it was proof that the meal was paid for. And she started eating because she thought she had paid for the meal. And she was very frugal. So that was a way to get her to eat. Encourage involvement in the mealtime. Have families, have them help set the table. Could they fold napkins? Could they help with some of the preparation? Or could they carry food to the table if it's safe? Play relaxing music to make them more comfortable. Use finger foods if appropriate, and they can no longer use the utensils, and they're going to save face that way. Larger meals in the morning. Remember that one utensil meal late in the day when they're tired. Or if afternoon is their good time, maybe that's when you want to give them their large meal. And then we want to remember that they should be served food that's appropriate for them, ethnically and culturally. We shouldn't be giving them things that they've never eaten in the past and they may not be willing to try. Some people are open to a lot more than others, trying new foods. I know we've been trying different things with my mother. My son made her a calzone with all these spices, and normally she never spiced. Her food was always bland that she cooked. And she raved about how delicious it was because it had taste. She could taste the spices, and she wasn't complaining about them. Use condiments. Suggest families put ketchup, which is sweet on food, mustard to give it flavor, pepper or salt if it's appropriate. What can we do to help them prepare prior to a meal? Encourage that they use the bathroom before meals if it's needed. Make sure that they're wearing their glasses so they can see the food, or that their dentures are in place for the meal and that they're not flipping around. Consider using adaptive cutlery. Get OT in there to help change the cutlery if they don't have that fine motor control to use what their family has at the table. Make sure we're keeping the food warm and appetizing, and use those colored contrasting plates. So the plate should be one color, the tablecloth or the placemat another color, so they can see that plate. Remember, they're having all those visual changes. And then again, avoid distracting items on the table at meal times. That can be very difficult for the person with Alzheimer's to concentrate. So think about it. What are their meal times like? If you're there during a meal time, try and observe. Is it very confusing? Or is there too much talking, too much activity? Do they have the TV on and the radio on and people are talking at the table? Maybe that's why they're not eating. They're so distracted. So we want to help do things so that individual with dementia can be successful. Are they in an assisted living and they're sitting with people they don't particularly like, or that upset them? Maybe they need to be moved to another table or eat by themselves. We had an individual at an ALF a few years ago, and she wasn't eating. The speech therapist was in there. She was being seen for PT and OT. And it turned out when they talked to the family, she had always served her husband and her children first, and whatever was left, she ate later by herself. So as soon as they moved her out of the dining room and into an area by herself, she started eating again because that was what was normal to her, and she was used to that routine. And think about it, is this a place where you'd want to eat your meal? Is there just too much going on, too much clutter, too much distraction? So we want to reduce the noise, make it an inviting environment, make sure that there's lighting. The more natural light, the better, so they can actually see their food. We talked about aroma. That can be very effective in getting them enticed to eat. Is the table height okay for the individual? Is the chair the right height? Can they see their food? How far away are they from their plate? Or is that too far for them to reach? Some other tips, we talked about promoting calm, making sure that they're at eye level with you if you're giving them instructions. Give them time. Remember that 60, 90-second rule. If you're giving or the family's giving simple cues, you want to give them time to respond to that. Also, avoid garnishes. Those can be confusing. Sometimes they'll eat them if they're not actually food, and it just adds to the distraction. Make sure we're serving them after they sit down promptly so that they don't sit there and get agitated. Make sure that they're getting liquids throughout the day. And again, we want to assure their dignity at all times. So if they can't handle a utensil, serve finger foods. Strong flavored foods, and we talked about that. They may like things that they had previously disliked. Keep an open mind. Tell families not to exclude foods. Let them try it. Maybe they'll eat things that they didn't eat before. But then keep a list of current preferences. They're not only their preferences, but their dislikes, so that they're not being served the foods that they don't like. We talked about spicing the foods. You can add extra salt if it's appropriate for the individual medically. And then offer sauces like chutney and relishes and vinegar, mustard, things that give things more flavor. Also, we'll talk about how to add calories. But if they're really struggling to finish the meal, we want to allow them extra time, maybe put them in a quieter area, serve one course at a time, keep the food warm and appetizing, and then maybe they need to be prompted and reassured throughout the meal. Dish up small amounts of food at any one time, and then if it's not working sitting at meals 3 times a day, consider 5 or 6 small meals rather than 3 large ones. And avoid taking their plate away when the family clears the table for everybody else, because they may need more time to eat, and we need to allow them extra time. So if they're not eating a lot, we don't want to add extra food, but we want to add the energy and protein to the food that they are eating. You can put whipping cream in milk. I've seen people put heavy whipping cream in potatoes, add butter, add sour cream. We probably wish someone would tell us that. Use those small meals. Avoid low-calorie foods if they're not overweight and you're trying to increase their nutrition. Add extra butter, cream cheese, sugar. Put jam and honey thickly onto toast. Fortify milk by adding powdered milk to it, or you can add instant breakfast type things or protein powder. What about the patient that wanders during a meal? Again, I learned this from a speech therapist. She used an ice cream cone. She had the family grind up his food and put it in mashed potatoes. So they'd grind up the protein and the vegetables into the mashed potatoes, and they just put a scoop on his ice cream cone. He'd walk around, come back, they'd fill it up again. Or leave snacks out on their usual route. Place that food so that it's easy for them to get. Encourage high energy foods when it's possible. And then change the meal times. If it's not the normal time that they ate, maybe they need to eat earlier. Or if they were someone who ate their dinner late in the evening, maybe that needs to be adjusted. But remember to do that large meal when they're at their best. And try and use make it a one utensil meal when they're tired. So what are some of the effects of swallowing on normal aging? I mentioned that we have reduced saliva, reduced thirst, our taste buds change, we have an increased likelihood of reflux, we're going to have reduced muscle bulk, a reduction in the strength of our tongue and facial muscles, and our cough reflexes also can be reduced. So what are some things that we could do to ensure that the patient's having a safety with swallowing and to make mealtime a successful event? Make sure that they are able to swallow safely, that they're getting their preferred food texture. Are we paying attention to how they're eating? Or is the family watching to make sure that they're swallowing and they're not swallowing 6 times with each bite? Do they have that ability to get the food from the plate to their mouth? Or do we need to change the utensil, change the type of food? And then we just want to make sure that we encourage families to have a supportive environment that can facilitate their independent feeding. So what are some of the risks and complications that we see? Choking, painful swallowing, malnutrition, dehydration, aspiration, pneumonia. These are very common in the patient with Alzheimer's. What is the prevalence of dysphagia? It's associated with advanced aging. It increases the incidence is approximately 44% in the geriatric population, and it's associated with significant morbidity and mortality. We know it can result in weight loss, poor nutrition, dehydration, skin breakdown, social isolation, aspiration pneumonia, and cause death. In home health, it's approximately 58% of the speech therapist caseload, which are dysphagia patients. And the number of hospitalized elderly Medicare beneficiaries that are admitted to the hospital with a diagnosis of aspiration pneumonia has increased almost 94% in the past decade. So what is dysphagia? It's the difficulty moving food and liquid from the mouth to the stomach. Some of the symptoms that we need to be aware of and make families aware of, and it's always a good idea to have a speech therapist do an evaluation and teach the family what the symptoms are, the things that they should be looking out for. Are they coughing, clearing their throat at meals, pocketing food in their mouth? Are they noticing they're not chewing food and they're swallowing it before it's fully chewed? Or do they have that sensation of being stuck? I had a patient in home care years ago, and she was always pulling on her throat. Well, we got the speech therapist in there, and she really was having issues. Her food was getting stuck there. Is it painful swallowing because they have oral cavity issues? Or aren't they swallowing? Are they just pocketing and leaving the food in their mouth? That wet, gurgly voice or breathing after they swallow, grimacing, some other signs, runny nose, watery eyes with swallowing food or drinking fluids. People with cognitive impairment often exhibit changes in their behavior at mealtime. And why is that? They have sensory damage that disrupts the ability to eat, swallow, and they can't always follow the treatment strategies that we've put in place. They have motor damage that affects their ability to initiate the swallow. It disrupts airway closure and pharyngeal movement. And the primary cause of dysphagia and dementia is actually the intellectual impairment. So due to that motor and sensory damage in a dementia patient, we may see exasperation, silent aspiration, bronchiectasis, dehydration, weight loss, starvation. And then this just breaks down some of the things that we're going to see in early stage dementia. They may have taste and smell dysfunction. They usually, in the very early stages, have that awareness of their cognitive deficits that can make them frustrated. They have some attention issues. They may be distracted throughout the meal. Their medications could be having effect. And they could be depressed because they know what's going on. And that could affect their nutrition and their ability to hydrate themselves because they just have no interest in it. In the middle stages, we may see more wandering, motor restlessness. They may need assistance with their oral care at this stage. They may have the cognitive-based dysphagia at this stage. Their attention is more impaired. It's moderately impaired, and they're distracted easily throughout the meal at this stage. They may have texture aversion. They don't like certain textures in their mouth anymore. Or they just forget to eat. They have that 5 minutes of short-term memory. Then in the advanced or late stages, cognitive-based dysphagia, dependence on oral care, oral apraxia, oral acceptance deficits, oral preparatory deficits. Their attention is moderately to severely impaired, and they're often very easily distracted. They again have that texture aversion. They may be on more medications, or there may be a change in medication that's affecting their ability to eat and drink. You may see more aspiration at this stage. They may suffer myoclonus, twitching in their oral musculature. Their ability to feed themselves is lost. They become dependent on others. Their oral prep and oral phase deficits, prolonged chewing and pocketing, open mouth posture. They have that residue after they've swallowed in their mouth, excessive manipulation time of the food, lingual pumping, and then they may have difficulty forming the bolus or throwing the bolus. What are some of the treatment techniques that we can use? Encourage families to use signage, written reminders, visual cues. If they're eating with them, to really overemphasize their swallow. Limit the number of utensils and make sure that they're appropriate for them. And I already talked about don't use garnishes or decorations. They may pick up and eat them if they're not. I've seen that in assisted living sometimes. Use one-step directives for cueing and encouragement and give them that time to respond. Make sure that the family's offering them liquid consistently throughout the day, and as well as toileting them so that they're not getting dehydrated. And then the speech therapist may suggest changes in body or head posture to help to compensate, to reduce aspiration or the residue that they leave in their mouth. But what about oral care? Breathing in the contents of an unclean mouth is the fastest route to pneumonia because the person will have already introduced ready-made bacteria into the lungs. Think about all the patients we've seen with the food pocketing. So we want to make sure that families are removing those particles after every meal. And how can we do that? If they won't let you use a toothbrush, you can try a toothette with an antiseptic mouthwash or hydrogen peroxide to make sure that they're cleaning out their mouth and getting that food. But again, if they're resisting, it doesn't necessarily mean that they don't want their mouth cleaned. It's maybe the way that someone's doing it. Maybe they need a short explanation, a simple explanation as I'm going to help get the food out of your mouth, or why don't we try to rinse your mouth out now? Maybe they could do that instead. And then as the challenging behaviors increase, so is the risk for disease increasing related to oral care and eating. So how do we tell if they're having dental problems? This may be the reason that they're not eating. Are they refusing their food, pushing it away? Are they not eating anything hot or cold or hard? Are they starting to pull at their face or their mouth during meals? Are they refusing to wear their dentures that they previously tolerated very well? Is it the individual that's having disturbed sleep, a lot of restlessness? Or are they flinching when they're having their face washed or when they're being shaved? Those can all be signs of dental issues. Are they becoming very aggressive or irritated with meals? So what can we encourage families to do for oral care? Make sure that they're using simple, concise directions, not complicated. Or they can use the watch me approach. They can demonstrate, brush their teeth at the same time, or they can do assisted brushing. So they're helping the patient to brush their teeth very carefully and not very rough, to be very gentle. So individuals with teeth, it's recommended by the American Dental Society that they should be brushed after each meal with fluoridated toothpaste and floss daily. That may be a difficult thing to floss their teeth. There's a lot of products out there that make it a little easier now. For individuals without teeth, after each meal, dentures should be removed and brushed clean. Each night they should be removed, clean, and stored in a cup of water with some kind of disinfectant or cleaner. And then gums and the roof of the mouth should be brushed after the removal of dentures, because a lot of times things get trapped underneath the dentures. And the recommendation is that they should be soaked in a cleaner at least weekly. I would think a little more than that would be a great thing to do. And then you can also encourage families to experiment with different toothbrushes, using a children's toothbrush, maybe a long-handled or a large-handled toothbrush that they could do it themselves, an angled toothbrush. Have the OT come in and modify the grip on the toothbrush so they could use it themselves. Electric toothbrushes might be easier in the early stages, but electric equipment in the later stages may confuse someone with Alzheimer's. And then the other thing we want to make families aware of is, they may have a sore mouth because they've got an ulcer in there, or do they have bleeding gums, toothaches, decayed, discolored, loose, or cracked teeth? Or is it poor fitting dentures? Maybe they've lost weight and their dentures no longer fit properly. Or there's actually a lot of medications that can cause dry mouth and make swallowing and chewing more difficult. Do they have an infection? And we want to encourage families to make sure that their loved ones are still getting regular dental checkups. Because although they have dementia, they can still have things going on in their mouth, and maybe they're not able to tell you. So it's really important that they're getting those regular checkups. I am